I'm going to talk about the monitoring, particularly cardiac monitoring, but also liver and the management challenges throughout that period of time. It's over a 20-year period, so please bear with me, and there will be bits that have been omitted and things throughout, but hopefully I'll give you a good overview of that. And then more recently, I'm going to talk about a couple of key admissions that this gentleman had, and the implications of those related to his treatment. And then touch very briefly, because I'm sorry I haven't attended earlier, so I'm sorry if I repeat anything, but touch very briefly on iron overload and talk specifically about the patient journey in relation to that. And then hopefully there'll be some points for discussion and questions at the end. So the patient's a 35-year-old male now, and he has transfusion-dependent thalassemia. He was diagnosed in infancy and was first transfused at the age of 3, and then regularly after that. Other things in his history, he had a diagnosis of, well, he had episodes of childhood seizures which required medication, but he never had a formal diagnosis of epilepsy, and he's been off treatment for a long time for those. He had a splenectomy, like with lots of our patients, at the age of 7, which may become relevant hopefully later when we're thinking about some of his problems. He also had some endocrine issues, again, like with a lot of these patients, hypothyroidism and hypogonadotrophic hypogonadism and problems of puberty. And again, like with a lot of these patients, he had some cardiac issues, and he had problems with arrhythmias. So he had some atrial fibrillation at points in his history. And more recently, he had on scans was found to have dilated cardiomyopathy, and actually a different arrhythmia, a Mobitz type 2, which required him being fitted with a permanent pacemaker. So quite significant events in his history. And so I'm going to try and talk you through from when he was transitioned from adults through to sort of 2012, and then the next slide will be more recent. So please bear with me. And I've just put along the bottom the medications abbreviations, because
sorry, Jane.
Oh, hello,
Jane. Just a moment, Jane. Someone's saying that the slides are not moving.
Can everyone else see it moving now or not? Don't know.
Yes.
Yeah.
Okay. Just carry on. If we'll let you know.
No problem. Just speak up if it doesn't make sense or if I'm talking ahead of where the slides. So this is basically a timeline between transition and 2012, and particularly I'm focusing on the cardiac function. And in 2004, when this patient transitioned, they were on the DFO and DFP, and because I get confused, I've put them at the bottom of each of the screen just so that you guys know which medications I'm talking about. And at that stage, he had a normal ejection fraction on echo, and I just thought it's important to think about what ejection fraction means. So just to highlight, probably sorry if I'm telling you things you already know, but ejection fraction basically is showing how effective the heart is as a pump. So it's as a percentage, and it's literally just saying that it's looking at the percentage of blood that's pumped out of the heart versus the percentage that's left remaining in the left ventricle in the heart. So the higher the percentage, usually the better the heart function is, and we usually use sort of 55% as a marker of good ejection fraction, and below that, and certainly below 40% would be an indicator the heart isn't working well as a pump. So as you can see, the next step I was going to talk about really was adherence issue. So he was on those medications when he came through from adults, but there was lots of issues with him not taking his medicines, and certainly with his subcut medicines, rather than having one infusion over 12 hours over 7 days, he would just back to back them and do sort of 3 days block of 24 hours of infusion. So lots of challenges really, and I imagine you guys are probably more experienced than me that a lot of patients have that kind of experience where they struggle with adherence, particularly in their sort of teenage years and early 20s. And throughout that period, although he turned up for all his transfusions, he rarely attended clinic, and he was quite difficult to engage with. In 2008, then he had an echo that showed that he had an ejection fraction of 38%, which is a significant reduction and a really worrying prognostic factor in terms of his risk of heart failure, and there were a lot of concerns about that. And then following on from that, in 2010, he had another echo and a cardiac MRI T2 starred, which I'll come on to, sorry, which showed the dilated cardiomyopathy I referred to earlier, and his ejection fraction hadn't really improved. And so all of those things are concerning, that there's a risk of the patient's heart function is deteriorating because of iron overload. In 2011, he challenged about what treatments he would like to be taking. He'd stopped taking his subcut medicines and himself, and he really wanted to try XJade. And so I've spoken to Mandini about him as a patient as well. You kind of have to work with the patient, like you guys all know, to see, because a treatment that you're on, if you're not taking it, is no use. So he was really keen to try the XJade, and so we did try that with him. He did have some problems with deranged LFTs over that period of time, and so unfortunately had to stop taking the XJade and then restarted the DFO at that stage, and all throughout difficult problems with attendance. So hopefully, I'm going to move on slides, so hopefully you guys can see the next slide. So I'm going to look at the now more detail, his more recent cardiac function. Is this all appearing for everybody?
So at the moment, I'm still on transition to 2012. It might just be a lag. No one else is able to see.
Okay. Now.
No.
Yeah or no? Sorry, can you see?
No.
Is it no? Okay.
Oh wait, now we can see focus on cardiac function.
Oh, it's just a delay then, hopefully.
I think it's just perhaps a few second delay now.
And is it a blank screen or is it
no,
yeah.
we can see focus on cardiac function, and we have like a diagram and some arrows and a box.
Everything's appeared at once. Okay, fine, yeah. No worries. I'll do that then. Fine. So if we start in July 2015, and his ejection fraction at that stage was 54% and okay. And what I've put in is the MRI cardiac T2 starred results and throughout this. And I thought it'd be important just to highlight, and you probably all know this, but just to revisit what that 6 milliseconds means in terms of, are we worried about his cardiac function or not from MRI? And if you look in the bottom right as you're looking at the screen, there's a block where we look at the MRI cardiac T2 starred and ejection fraction, and we would usually expect a baseline cardiac MRI to have happened age 8. And then how often we measure the cardiac T2 star after that depends on the outcome of the initial baseline. And you can see if it's below 10 milliseconds, then we do it every 6 months because it is a concerning feature. And so his at 6 milliseconds in July 2015 is a bit of a worry. And if you can see at the bottom in the red, I've highlighted why, and these are all from the BSH guidelines, but that a patient with a T2 starred of less than 6 milliseconds, the chance of them developing heart failure in the next 12 months is 50%. So, and the morbidity and mortality associated with heart failure is very significant. And so this is really quite a worrying sort of sign for him from a cardiac perspective. And interestingly, at that stage also, and you'll see further on that this doesn't always correlate, his liver iron concentration was the highest it had been on record for him at 14 as well. And in the top right of your screen, you can see that why we worry about that, and the two key numbers being the 7 milligrams per gram dry weight, showing that the liver would be at increased risk of fibrosis, and the 15 milligrams showing there'll be an increased risk of myocardial iron overload. And with him, and thinking back to his history, he's had a splenectomy, and what we do know is patients that have splenectomies don't always necessarily have this high liver iron concentration that sort of predicts myocardial iron overload. Sometimes the liver iron concentration can be normal, but they have significant cardiac issues. So just going back to, so in July 2015, he had this ejection fraction of 54%. And then he presented unwell with in November 2015, bradycardic and a low blood pressure. And this is where he had this noted arrhythmia, Mobitz type 2, and needed the pacemaker fitted. And then the following year, we're tracking his cardiac function again, and it's dropped further. So his ejection fraction now is 36%, and his T2 star was a real low at 5.6 milliseconds. Interestingly, there you can see his liver is actually a lot lower than it was in 2015. And all of this period of time, he was on DFO and DFP. And again, the challenges were with compliance, clinic attendance, and sort of engaging him in treatment. And then I suppose if we jump through to now November 2018, you can see that the ejection fraction is okay at 50%. The T2 star is still low, not critically low, not as critically low as below 6, but still below 10. But his liver iron concentration had jumped again. And at that point, there was sort of lots of discussions about him and what treatments we should do. And so he was changed over that at that stage to XJ'd again and kept on his DFP. So had sort of 2 oral combination therapy as opposed, and stopped the subcut that wasn't really something he was adhering with. We tried to increase the XJ's dose, but again, he had these abnormal LFTs that were associated with that. So in the end, the sort of plan was for a high dose of just the single agent, a DFP, and to try and encourage adherence and compliance of his treatment. In between November 2018 and 2019, you can see that he had an admission. I'll come on to that admission at that stage and what else went on for him. But he did see some improvement in his cardiac parameters and also his liver parameters. So there was a good response to treatment. But there's and then again in August 2020, and there's a couple of admissions through this period of time that I thought would be interesting to look at in terms of the side effects of the medicines. So I'm going to change slides again. Hopefully you can stay with me. This one's not got anything built in. Can everybody see this slide? So basically then in August, we talked about what happened towards the late end of his sort of that timeline that you just saw. And in August 29, he had a very prolonged admission. He was admitted initially with some chest symptoms and treated for pneumonia. But when you spoke to him, he had a history of worsening fatigue, breathlessness, and quite significant peripheral edema. And he was sort of found to be in clinical heart failure. He hadn't been taking his XJ at that stage, and he was just on the deferoprone. And you can see, just looking back, that was the result that was sort of the most recent cardiac MRI at that stage. So, you know, his heart function was not looking particularly good from the parameters we used to measure iron overload. So at that stage, as per sort of BSH guidelines, he was restarted on deferoxamine DFO IV, and he had that for 13 days. And what we saw during that period, he had a couple of episodes with low GCS, and then eventually he really dropped his GCS and needed to be intubated. And this was thought to be a side effect of the desferol due to, the dose had to be reduced quite significantly. And we'll come on to maybe talk about that with Nandini later about what potentially might have led to that. But we thought it was a sort of toxicity associated with the desferol at the time. He also had some sort of dissociative pseudo seizures during this period of time, and they were extensively investigated, and there was no obvious cause of those found either, but just as a sort of side that was happening during this prolonged admission. And then on discharge, he was discharged on combination therapy and went home on both of those treatments. And then he came back to us. I'm going to just go off and on again just to see if that. He came back to us in April 2020, and again he'd started becoming more and more well known to the cardiology team, to the general medical team, because he was in so frequently. And at this time, he had in April 2020, he had 6 or 7 admissions with symptomatic hypokalemia. He sort of had a prodrome when he knew he dropped his potassium, with fatigue and muscle weakness came in and was found to have sort of a potassium between 2 and 3. Usually it responded to IV potassium and oral supplementation, but after a few days this would all sort of drop and he'd end up back in hospital. And during that period also, he had these, I know he'd had the dissociative seizures, but there was also some episodes of sort of odd paralysis with low potassium as well. And again, extensively investigated, and we got the renal team involved with him at this stage. And he was thought then, the reason for this low potassium was thought to be due to a sort of a renal tubulopathy. And that sort of carried on for 18 months. And again, we think that was most likely a side effect of his iron chelation. Interestingly, if you look at the sort of literature, usually it's XJ that's associated with these sort of renal tubulopathies, but in the context of this, we felt that this was more likely to be secondary to the deferoxamine. And so he was continued on just a single oral treatment, and actually has done really well since then. So if I come on to where he is now, the renal tubulopathy is all resolved. Oh, I've missed, I've got a slide that come through that wasn't supposed to be. Is that, can you see that slide? Oh, gosh. Sorry. So yeah, sorry. So as part of this admission as well, sorry, I've just showed you his ECG because it terrified me, but he had a prolonged QTC that was potentially associated with his potassium as well, which was now normalized. And from a treatment perspective, he has started and stopped XJ and started and stopped desferoxamine. The desferoxamine was key to be stopped, and that really was linked with the improvement in his electrolytes, and the deferoprone was continued on. He was discussed at the National Hemoglobinopathy Panel, and from a management perspective, the sort of consensus was that the deferoprone alone would be a good single agent over the next 6 months and see how he responded to that. But actually, it just didn't seem enough, and he was getting clinically worse rather than better. So XJ had to be added in, and so, but both at a very low dose, given that he's had toxicities associated with lots of things, and especially with the XJ and the recent tubulopathy. So where we are now with this patient is that he's still regularly transfused 2 to 3 units every 3 weeks. He's currently on the low dose of the deferox and the deferoprone, but his cardiac function is significantly improved from when he sort of first presented in 2015, 2016 with the deterioration. So his T2 star most recently is 16, so much higher in double figures than it had been for many years previously. His ejection fraction is normal. His liver iron concentration is low, and his ferritin, which I didn't present to you throughout the presentation because I thought I was going to give you too many numbers, which was always in the sort of between 1,500 and 4,000 at its highest. It was 700. So he's really, really improved, and interestingly engages with treatment and clinics much more. And I think partly that's due, if you look through the notes through the persistence of all the team looking after him, to try and facilitate as much as possible whenever he attended, to try and get as many things sorted for him as possible, because he had to see cardiology, renal, he was seeing our team with transfusion, our team in clinic. There was an awful lot going on, and he lives quite a way away from the hospital. So I think that's one of the learning points we're going to discuss is how to best facilitate all of this for the patient. So most of the sort of parameters and figures that will have been that I've shown you through there were from the BSH guidelines. I hope you can see this slide moving on. I'll put it on like that. From the BSH guidelines, and I definitely recommend having a look through. They have everything. I'm sure you probably know them better than me, but they have everything that we've looked at in there, and certainly the management and the changes in treatment and the management of the acute heart failure that he presented with is covered within there, and what to do. And again, this was from I'm going to show, I can't search, don't know if you can see my diagram, but again, this diagram was from those guidelines, and it's sort of, and you might have seen this already earlier in the day, sorry if it's a repeat, but basically what it's showing is that with the transfusion, the blood that's being received from transfusion, the excess hemoglobin, the heme is taken up by the macrophages, and eventually the iron is sort of released back into the circulation and bound to transferrin. But once that transferrin is saturated, you get this NTBI, so this non-transferrin bound iron. and that links onto all sorts of things like albumin and all sorts, and finds its way into all of these organs that you can see in the picture. And with this patient, I thought it was really interesting because he almost had every possible toxicity associated with iron overload. So you can see he had the endocrine issues, he certainly had the heart failure and the arrhythmias. So far, his liver has been relatively well controlled, but our job now, I guess, is keeping that the case, and so preventing liver failure and things like diabetes from developing. And like I touched on in the when we spoke at the end of the case, this is from the BSH guidelines as well, and it shows that the pathway of the patient. If we look at the adult side of things, which is, again, I normally look at the pediatric side of things, but the adult side of things, one of the key things is to monitor for challenges and life pressures for compliance and treatment. And this patient really had lots of issues with adherence and struggling to manage his treatment burden. Also the sort of relationships with staff. So I think it's really clear when I look through all the notes and the documentation of this patient that he had lots of communication with lots of different members of staff. And I think certainly since he's become more unwell over the recent months, he's definitely more compliant and comes in to see to clinic much more frequently. And creating that work-life balance and talking about how we can, when a patient's under 4 or 5 specialties because of their iron overload, how we can best facilitate that for them and make sure that they see everybody, and ensure that he comes to all his monitoring appointments and his scans, which would have been really helpful, and he had missed quite a few of those. So just to summarize, really, I think one of the key things to note from this is, I think before I started, I thought myocardial iron overload would be pretty catastrophic for patients, and it can be, but what it is also highlights this presentation, it is reversible, and you can see the significant improvement because of the perseverance with treatment and trying to find the right treatment that fits for the patient, and supporting them through and being flexible with treatment. So that was what the main learning really points were from this case. And I don't know if you can see the slide, but yeah.
Yep. Thank you, Jane. That was a really comprehensive review. And I think the case is really to illustrate some of the challenges you get in the 18 to 26-year-olds, and finding a solution for a treatment that works for them. You cannot afford to give up on these patients, no matter how badly they misbehave sometimes. And it's the challenges with toxicity. The one other point that was never mentioned is TAL intermediates are prone for small kidneys or nephropathy, while he had a normal renal function.
Nandini, you've gone on mute again. Okay, so whilst we just wait for Nandini to try and get her voice back, we do have a question from Barbara Jane, asking, did the patient receive any psychological support?
I did so early days from when I've read things. I don't know whether Nandini might be able to highlight whether he did more recently, but certainly from what I could see, I haven't seen very much from his adult notes. Yes, apparently Nandini said he was offered psychology, yeah.
Brilliant. Fiona?
It's me because I couldn't log on my own.
Hi, Grace.
And there's an internet problem around MFT, Oxford Road. So we just got the email, so I've been trying. Thank you, Jen, for your presentation. Very, very important. But what I wanted to know, during this journey of this patient, I suppose it must have been done, transportation, bringing him in and out of the hospital because he had so many times to attend. Was there any provision made for him from the beginning to know this journey is going to be a long one, so you don't need to bother about transporting yourself to the hospital? Was there any plan for that, please? Thank you.
Great, Grace. So you mean day to day when he came for his transfusions was transport in place? So yeah. So if we take Manchester, he lived quite far north of Manchester, so there was quite a significant travel burden for him. And I know certainly there was this. I can only comment on the discussions in the notes, and certainly lots of things were offered to him. Whether he engaged with that, I don't know the answer. I know.
Sorry, can you hear me?
Yeah, we can hear you, Nandini.
Right. So So the issue was this is a family of 4 siblings who had Thalassemia, and they all came together for a weekend transfusion. Transport was never an issue, but I think more than anything, like a typical 18 to 20-year-old, he really struggled with his younger days. And when things were improving, and he asked him, to reflect on what went on, he says, "I was messing around, doctor. Thank you for putting sense into me and not giving up on me." Because, if we give up on them at that point when he just wouldn't come for his clinic appointments, we had to go down and catch him when he had his transfusions. He's very pleasant. I think they just didn't quite understand the severity of things that could go wrong, and also the fact that nothing will happen to them. The doctors will always intervene and save them. That's that overconfidence that everything will be fixed. So it's a bit of maturity kicking in, and patience and perseverance is the key for these patients. I haven't got an easy answer. And I think it's just to highlight that, despite having all the different chelations, MRI technologies, psychology was offered, it's that regular contact with the patient, being aware about toxicities that can occur to these patient group. I will offer him Desferal again. I hope he never needs it, but at a much lower dose, having had dropped with the tubulopathy and the low GCS and his small kidneys, which you can see with Thal intermediates. That was only picked up once he had the coma episode with the Desferal back in 2019. So I think in the interest of time, Sabiha, I think I'll get you to start with your talk because we've done thalassemia the whole session, and I don't want to exclude the rare anemia. So Dr. Kausar is going to be talking to us about a DBA child and some of the challenges that you can have with the transfusion and iron loading. And Dr. Kausar is a pediatric hematologist working at the RMCH. Sabiha, over to you.
So we'll start. So yes, I'm going to give you sort of a whistle-stop tour through diamond black fan anemia, and I was conscious that I'm the sort of last speaker and things, so it's not too technical. And what I just wanted to get across is sort of the journey through a patient with diamond black fan anemia, sort of from beginning to sort of definitive treatment, and then some of the sort of issues that can crop up along the way. So to give an overview. So the case that I wanted to discuss is an 8-week-old baby boy, and this is a case from when I was a registrar here, so some years back. And he presented to us sort of with a sort of normal pregnancy history with mum, a normal delivery, nothing uneventful at birth, went home and then was sort of feeding, and then the feeding sort of tapered off and he developed pallor, which sort of was noted from birth, but then sort of worsened over the 8 weeks and then presented to his local sort of unit and was noted to be quite small on the centiles, and then had no obvious dysmorphic features. And then when some bloods were taken, the marked things that were noted on the full blood count was that the hemoglobin was low at 43. He was macrocytic, and this is quite an important feature. And then the reticulocytes were very low at 4. On taking the history, there was no significant family history, no consanguinity, and no sort of illnesses known in the family. He had an older sibling who was fit and well. So with that sort of low hemoglobin and being about sort of 8 weeks old, we know we do get a sort of a physiological dip in hemoglobin around that age, but this was considerably lower. And therefore, we managed him by giving him an initial red cell transfusion to make him safe and well for the moment. And then some initial bloods were sent off. An important blood test to mention sort of before giving the red cell transfusion is a blood test called EADA, or erythrocyte adenosine deaminase, which is an enzyme within the red blood cells. And we know that this is raised in the red blood cells of patients with diamond black fan anemia. And it's important then to get that sent off. It's sent off to a lab that, well, we usually use a lab in London, which is the Viapath lab, to their Purine biochemical department, and they turn that around for us in a matter of weeks. And it's nice to have that marker, because before you have any definitive diagnosis, this gives a very good idea of what you might be dealing with. And then as we then moved along and made him safe with the transfusion, he remained an inpatient for a short period of time, and we were able to send off some other bloods looking for any of the genetic markers which would give us an idea of what might be going on with that very low hemoglobin. And the beauty of things nowadays is, compared to sort of previously, is that we can do a lot of the genetic bloods from sort of just a peripheral blood sample, and we don't need to always send off sort of bone marrow and put the child through a bone marrow aspirate for those sort of more sophisticated tests. Then what transpired over the next few weeks was, with this little boy, was that there was a need for further red cell transfusions. And as he was little, he was about sort of 4 kilos, the challenge then became for access in terms of bleeding him and giving him the transfusions. He was then placed on one of our theatre lists for central access, and because he was going to have a general anaesthetic, it was the opportune time to then do a bone marrow aspirate opportunistically at that point. And what we found on the bone marrow was that it showed erythroid hypoplasia, which was in keeping with sort of the diagnosis of diamond blackfan anemia, or a pure red cell aplasia. And what that simply meant was that when we looked at the bone marrow under the microscope, what we saw was that there were not as many red cell precursors, or the early red cells that we would want to see on the bone marrow in an otherwise well child of that age. So in summary, for this case, we had a baby in the first year of life, so an infant with anemia, with a reticulocytopenia and an elevated EADA. And those 3 features on sort of simple blood tests can give you a sort of a clinical idea of what you're dealing with. And then this tells you that there is something wrong with the sort of red cell production. And then we look at the bone marrow and we see erythroid hypoplasia. And then this gives us the clinical diagnosis of diamond blackfan anemia. We then, in terms of the genetics, what are you looking for in order to make that definitive diagnosis? Nowadays, we can do sort of whole exome sequencing of blood, and then we can identify sort of pathogenic or heterozygous variations. And this child had an initiation codon variant, which predicted to result in an untranslated protein in this particular protein called RPS26. And RP simply stands for ribosomal protein, and we'll talk about that in a bit more detail. So essentially, what does this mean? What does all this sort of genetic jargon mean? It means that the mutation he has, what it does, it takes away or eliminates the start codon, which is needed to be able to translate into a sort of a functional protein. And if you can't make that protein, the protein cannot then do its job, and then you lose sort of function, and what you get is a reduced amount of red cell production. The ribosomal protein gene known to cause autosomal dominant diamond blackfan anemia, and that's what this child had, an autosomal dominant form of the DBA. So then what I'll do is I'll move away from this case now, and we'll sort of talk through diamond blackfan anemia, and we'll sort of bring back this patient in terms of how we managed his treatment as we move towards the end of sort of progressing through the slides. So in terms of what is diamond blackfan anemia, so it is an inherited bone marrow failure syndrome, and its hallmark is pure red cell aplasia. It's usually diagnosed in the first year of life, and that's really important in pediatrics, because sometimes the information that you get from the history in terms of what age they present makes a big difference in terms of the differential that you consider. There's a risk of developing specific malignancies with this condition, and it's associated with other congenital anomalies. So again, the very basic things of taking a good history, looking at your patient properly and examining, and looking at the basic blood parameters gives you lots of clues before you make any sort of definitive diagnosis. And then obviously the diagnosis is made by looking at the genetic changes, but it's also important to know that maybe up to half of the cases you may not find an underlying genetic variation or mutation. They present often classically in infancy, as we said, and the symptoms, as with our patient, pallor, lethargy, poor feeding, a failure to thrive, and there may or may not be some dysmorphic features. There can also be some sort of non-classical presentations, and these can be through pregnancy. So we may have a child who is diagnosed, and then you go and check the mum or the father, and then you find that the diagnosis is present there also, and then following the diagnosis of their child. In terms of the physical effects, so again, as we said, some may or may not have dysmorphic features, and what we look for as we go through the sort of systems is craniofacial changes. There may be a small head, wide eyes, a flat nose. There may be small low-set ears. There may be a small bottom jaw, and there can be associated cleft palate or lip also. Moving down to the neck, there's a short webbed neck, and there's small shoulder blades. Anomalies with the thumb are sort of more commonly reported when you're looking at DBA, and often what you see is a triphalangeal thumb, so a thumb that looks like a finger with the sort of triphalangeal joints. There can be cardiac anomalies in terms of VSDs, ASDs, and there can be more complex anomalies as well, such as coarctation of the aorta or mitral valve prolapse. Musculoskeletal abnormalities are also seen, and there's growth failure. So if there's a delay in diagnosis because you can't get sort of the more sophisticated tests, plotting the growth over several weeks or a few months can give you some clear clues about what may be going on. There may be neuromotor associations more rarely, and things like hearing loss have been described also. So just to sort of illustrate some of those, the triphalangeal thumb that we can see, some skin changes as well, some hemangiomas can be seen sometimes, and dental abnormalities can be seen. And what often you see is that the teeth themselves are not sort of cavitated or bad in that sense, but what you see is this dental malocclusion or crowding of the teeth. And this other picture that just shows a repair from a cleft palate that's been seen in one of the patients. So moving back to the sort of basic blood tests, a full blood count can give you all the clues. A pancytopenia is sometimes seen, but sometimes you just see a very low hemoglobin, and then there's this increased MCV. So the macrocytosis is always a clue. So what I always often ask is that first full blood count, when it's been taken without any transfusion being given, what is the MCV on that first full blood count? And that's often a clue. The reticulocytes will help you because it will tell you that the bone marrow isn't effectively making the red blood cells. You look at the liver and renal function to see if there's any other associated problems. And as we mentioned, the raised EADA enzyme, which we would need to send off to get an answer back for. Interestingly, also, there's a raised fetal hemoglobin that is noted. And of course, if you have a very young baby like ours who presented at 8 weeks, of course, the fetal hemoglobin will still be quite high, as there will be that sort of changeover period to the sort of normal hemoglobins. But what you might find is that it might still be more raised than what would be expected to be in the appropriate range. There is also an association with immune function affecting the B and T cells, so it's always a good idea to send off basic B and T cells, immunoglobulins and electrophoresis for a baseline immune function. The bone marrow test, which we alluded upon earlier, as I said, nowadays we don't need to do the bone marrow test to sort of give the definitive diagnosis, as we can get the results from the peripheral blood, but often what the features that we can see on the bone marrow aspirate are very convincing and very characteristic, and the morphology will give you a lot of the answers. The additional benefits of doing sort of a bone marrow is we can send off for cytogenetics just to see if there are any other worrying things which might be there in addition to the diamond black fan anemia. And again, as we said, what you'll find is this reduced numbers of red cell precursors, and there may be some abnormal cells there as well. And as part of monitoring surveillance, you would do repeated bone marrows on these patients to see any evolution. So there's just some pictures there of some bone marrow aspirates, and what we can see sort of in the lower power view is we can see lots of these big cells, and these big cells are not the sort of erythroid cells. So you can see the big cells, which are the myeloid cells making the sort of white blood cells, and the neutrophils are there in predominance, and the erythroid cells which are few and far between, are sort of scattered in between, whereas there should be a sort of a predominance, if you like, of the erythroid as well alongside the myeloid cells. And then in the higher power, again, those bigger cells are magnified, and you can see these are the sort of early precursors of the neutrophils, and you can see some of the segmented neutrophils there, but there's a lack of any of the erythroid precursors completely. The genetic test, again, as we said, look for the genetic mutation through the blood tests. And what we find is that in some of the patients, it's an inherited form, so it's passed on from the parent and child, and then that sort of sets off the investigations for the other family members to see where it's come from. But sometimes you see a de novo change, so the genes change on their own and are specific for that child. In terms of going back to the cytogenetics and the molecular parts of the sort of condition, again, as we said, it's sporadic and familial, so it's important to sort of delineate that, and a referral to the genetic teams is important, and then to sort of determine in what fashion this is inherited, as this then allows you to give advice not just for the patient but also for family planning ahead for future pregnancies and future children. The mutations are many, and there's several have been identified as we've gone sort of over the years and through research, and a lot of them have this sort of RP at the beginning, which again is telling us it's the ribosomal protein that's affected. And as we mentioned, the ribosomal proteins, and as shown in the picture here, are the proteins that process the cell's genetic instructions to make proteins. So if you're not making sort of functional proteins, then there's a stop very early on in terms of having functional red cells in this case. The immune deficiency, which we mentioned earlier, is reported, and it's important to measure and look at that immune system function annually when you have these patients. The quantitative important advice and look of risk infections, particularly if you have a baby as ours, when you're putting in an access device such as a port or a central line, which then adds to that risk of infection. Once the diagnosis is made, the management is in a tertiary care centre, and the explanation to the family, of course, is the most important thing here, to sit down and discuss carefully, and to explain that this is going to be a sort of a chronic condition that's going to require multiple disciplinary teams, nurses, which are all sort of very key to following up and looking after this patient. And what we find is the families need a lot of support in the initial period, and having that support and having that contact with the tertiary care centre is very important. It's important when you talk to the families to discuss the evolution of the condition. Then in some cases it's transient, but this is sort of much more rare. There can be spontaneous remission, but the children that we see and then the genetic diagnosis when it's made show that that's going to be a longer standing condition which requires definitive treatment. They can be associated other lineages affected in the full blood count with the platelets and the white cells being affected, and there can be an evolution to an aplastic anemia picture, which again would require more definitive treatment. So in terms of the management, as we mentioned with our baby at the beginning, when obviously they are very anemic and the hemoglobin is very low, the mainstay treatment is keeping that hemoglobin safe to allow them to, first of all, function and then to grow and develop in an appropriate way. When we give regular blood transfusions, we know there's always that knock-on effect of iron loading, and then the iron chelation becomes a key aspect in the management of these patients. To try and sort of alleviate from that regular blood transfusion requirement, steroids are now sort of a mainstay of treatment, and a trial of steroids is always introduced early on to see if we can wean them off the transfusions. And then the definitive treatment, which is the bone marrow transplant, is talked about early on to see what the options are for that particular patient, to see if there is donor availability, to see what can be put into place in advance if the need is required after sort of steroids and blood transfusions. So in terms of transfusions, as we said, is the mainstay of treatment. We have a robust transfusion system in the UK, which allows us to give transfusions safely and effectively. And when we start off with these patients, we sort of give a sort of initial 4 to 6 weekly, but each individual patient will have their own need, and we tailor that to how we see the growth and development, what we see the indices to be, and obviously what the access allows. And what we find is that when we do have young children, sort of around 1 year of age, through the sort of early years up to about 5 years of age, the majority of them do require some sort of access to get the transfusions in. As the transfusions go in, the iron loads, and then it's important to now sort of monitor that. And we always do that sort of very simply through the ferritins, through the blood, but we know that they're not the most accurate way of looking at iron loading. And then the specialist scans are really important, but there's a balance because we need to do these effectively. And in the very young children, this can be challenging. So I think whenever there's a concern with iron loading early on, you're obviously waiting for them to be at a good age where you can sort of get a good result from the scan, but always consider doing them under general anesthetic or sedation, because that result will actually determine how you manage the iron loading and how you chelate them. The ferry scan, the liver scan, can be done sort of at a much earlier age, and sometimes I do it in younger children at about 3 years, or even younger with a GA if we're worried that there is worries about iron loading. And the T2 star, which looks at the heart iron loading, can be done when they're a little bit older, but we start to do that at around about 6-7 years of age. So the steroid treatment, so we think about this early on, but we don't think about it before the first year of life, because we know that in the first 12 months, the growth is exponential. It's very fast, and there's a lot of development happening, neurological development particularly. And what you don't want to do is you don't want to stunt that or slow that down. And so we usually wait until they're over a year of age. And it also then gives us an idea of sort of their transfusion requirements, the ease of giving transfusions and all of those things. And it gives you time to sort of spend with the family to say that we've now introduced the transfusions. We want to see how we're doing. It gives us a bit of time to build that relationship with the family. The trial of prednisolone is then started, and the standard is around 2 milligrams per kilo for 4 weeks. And what you want to do is you want to go in with a decent dose of steroid and then start to wean that fairly slowly, but to sort of chip away at it. So to bring it down in sort of very small increments, but then consistently over around the next sort of 3 to 6 months or so. And what you want to achieve is really a good hemoglobin with a very minimal amount of steroid, so that you minimize the risk of the steroids on growth and development and all the other side effects that come with steroids, but also then to maintain a hemoglobin which is sufficient for good growth and development. And the challenge is always that these are pediatric patients at this age, so growth is really important, and it comes in different phases, but then to try to sort of maximize on that, but by not compromising the other care. And as we mentioned, the iron loading we can do with sedation or GA early on, and the same for the T2 star. And then what we find, if we then start to wean off the steroids and the hemoglobin starts to drop, and sometimes it may drop slowly or it may crash, it will be evidence to say that the steroids are not going to work for this particular patient. And then it's returned to the standard of care, which is the regular transfusion program. So just coming back on the side effects of the steroids, as we know that there are sort of many systemic side effects, and all of these need to be taken into account. So we need to be examining the patients, looking out for all of these things. And early on, you may not see these, and it may be over a period of time, but even a very small amount of steroid over a long period of time will start to have effects. So it's important to involve other multidisciplinary team colleagues like your endocrine colleagues early on to make sure that the patient is managed effectively for all of the other side effects or complications that could occur. And then surveillance. It becomes very important if you've got them on a regular blood transfusion program to their iron loading is sort of managed meticulously and fiercely, and we have now good robust guidelines, as mentioned in the earlier presentations, to follow in terms of keeping that iron under control. Sometimes you may need to sort of do liver biopsy to get more information in terms of the evolution and the effects and the complications of iron loading. The MRI T2 stars we mentioned for the heart, and the regular bone marrow aspirate. So ideally what is said is that this should be done on an annual basis. So 1 to 2 yearly is what we would do for our patients. And again, that's to look for that evolution, to see if there's any abnormal clones which may be evolving, to make sure that we're on top. And it's not just the red cell side of things that we're looking after. DEXA scan to look at the bones in view of giving the sort of steroids. So if they are a patient who's responding to steroids very well, that's brilliant, that's good, we've got them off the transfusions, but then the complications of the steroids need to be monitored and looked after at the same time. Monitor the film, the blood film. Sometimes the blood film can give you clues to changing things before jumping in with bone marrow aspirates and things. Vitamin D, this is also all to give us sort of a holistic management. We know more and more that this can sort of impact on all the other sort of complications and symptoms, and this should be all included in your sort of MOT or surveillance of the patient. So more definitive treatments, as we mentioned, then the bone marrow transplant. This offers the definitive long-term cure. And what are the goals? Are to normalize the red cell indices so that the patient is transfusion free and without the side effects of long-term steroids. And what you want to do is achieve a full engraftment so that, you know, the patient isn't coming back for ad hoc transfusions and things. What you want them to be is transfusion free. And what you want to do with a transplant for a patient such as a patient with diamond-blackfan anemia, because it's a patient which is not being managed for a malignancy, or, you know, it's not a cancer patient as such, is you want to minimize the short and long-term toxicities of the transplant. You want to minimize the risk of infections. You want to prevent graft versus host disease, because that's of no benefit in this condition. The transplant would also remove any clones or if there's any MDS in the bone marrow. But what's important to recognize is that it doesn't remove the risk of solid tumors, which is inherent and part of the DBA, which is there from the beginning. So when considering for a bone marrow transplant, you consider it early on, as we mentioned, and we consider the health status, the age, the organ function, the iron status, and the steroids effects. So all of that tells you, you know, how fit is your patient. And this brings us back to, again, think of this early on, because when children are young, they're more likely to be more fit and more well, have good organ function. They haven't iron loaded so much, and the steroids haven't been around long enough to have the detrimental effects. The other things that need to be considered alongside the patient are obviously the donor availability, the stem cell source, and how are you going to condition, how are you going to prepare this patient's bone marrow in order to give the new stem cells. So the donor ideally is a matched sibling donor, and this won't always be the case with all families, as there may not be any siblings. And then you look for the matched unrelated donor in the national and international registries. And then you may also consider a parent as a match, as a haplo for a possible transplant. But the preference is always a fully HLA matched sibling in the first instance. The stem cell source, so we consider where the source comes from. So when you've identified our donor, is it going to be a bone marrow? Is it going to be peripheral blood? Is it going to be umbilical cord? And for our patients, ideally, what you want to use is the bone marrow, because with peripheral stem cells, there may be a decreased risk of rejection, but there may be an increased risk of graft versus host disease, which you don't want. So conditioning, so how are we going to clear the bone marrow? In terms of clearing the bone marrow, what you want to do is clear the bone marrow, but at the same time not cause additional risk to the patient. So you have to consider if we're going to use myeloablative or a reduced intensity or a non-myeloablative conditioning regime. And now we have sort of robust guidelines and protocols in place from the transplant team, which have a set standard for the DBA patients. And in terms of engraftment and follow-up, we know that the patients will need an inpatient stay of around 6 to 8 weeks, and sort of around 2 weeks after receiving the stem cells, we start to see sort of engraftment. The follow-up is sort of very intensive, sort of coming back to clinic 2 to or 1 to 2 times a week, and seeing and having blood counts done and seeing how they're doing clinically. The beauty of sort of bone marrow transplant when it works and works well is that by about 1 year, when you've got sort of full immune reconstitution, you can be off all medication bar sort of prophylactic penicillin, and then there's sort of continued monitoring for sort of the longer term effects. So when considering sort of bone marrow transplant for the diamond black fan anemia patients, it's always a risk versus the benefits, and these need to be balanced out and discussed with the family. And I think it's really important because what's happening with the patient is that they're moving from a benign hematology team to a malignant hematology team or a transplant team, and that communication with the family to transition them over is really important. And this is where that interaction between sort of the nursing team, the medical doctors and the family is so key. So, we are the best advocates for our patients, working with the family, and the important sort of key messages for sort of the diamond black fan patients or patients where we have got the rare anemias and definitive treatment is being considered, or any treatment is being considered, is to refer early, proactively plan, look at what is going to happen to your patient in the next 5 to 10 years, because when you have a fit and well child, it's easy to think that everything is going fine, but what you need to do is plan ahead. Transplant is always an option for older and sick patients also. And I think Nandini has, presented patients where we felt that, because they're older, because there's so many complications, they're so iron loaded, that the options are very limited. But actually, if you're slow and you persevere, you can actually get them out of that troubled period and get them on the right track. And we have to advocate for our patients, because sometimes with chronic conditions, what happens is that you tend to think that we've come to an end and the options are limited, but that's not always the case. So just briefly back onto our patient. This is our patient, the younger one, who had diamond black. He's now transplanted and doing well 10 years on from his transplant. So thank you. That was just a quick tour through DBA, and I'm conscious that was last speaker. So
Sabiha. Can you hear me?
I think yes, I can hear you now, Nandi. Thank you.
Amazing. Yeah, no, wonderful. It was such a wonderful presentation and a nice end to the session. Actually, I'm always conscious we're doing always thalassemia, and we shouldn't forget our rare anemia patients. So it was wonderful. Anyone has any questions to ask? I'm very conscious we're almost half an hour over time, but do anyone have any questions they want to ask? If not, we'd really appreciate some feedback to know if there's things that could have been done better, differently. I do apologize, technical issues on our trust site on Teams, which has been rather challenging, and thank you for your patience on all of that.